Okay, let's map this out so you know exactly where we're headed. Here is our clinical pathway for today. First, types and risk factors. Second, presentation and diagnosis. Third, staging the cancer. Fourth, surgical treatment. And finally, palliative and benign care.
Section 1. Types and risk factors.
Right off the bat, there is a very stark contrast between the two major culprits here, squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma is the most common esophageal cancer overall globally, and it's especially prevalent in countries like India. It preferentially strikes the middle one-third of the esophagus. Adenocarcinoma, on the other hand, is often described clinically as a rich man's disease. It's far more common in the developed Western world, and it specifically targets the lower one-third of the esophagus. Now, what's really interesting here is that while smoking and alcohol are huge culprits for both types, adenocarcinoma has its own unique pathological pathway. It is heavily tied to obesity, GERD, Barrett's esophagus, and Crest syndrome, which, as a quick reminder, is a specific type of scleroderma.
Now, squamous cell carcinoma has an incredibly diverse, highly tested set of risk factors. Let's just rapid fire through these. You've got tylosis, which is an autoimmune condition causing palmar plantar keratoderma. You have motility disorders like achalasia cardia. There's Zenker's diverticulum. You've got corrosive injuries from acids or alkalis, which actually carry a massive 6 to 8% long-term risk. And of course, Plummer-Vinson syndrome, also known as Patterson-Kelly-Brown syndrome. But here is a fascinating fact. Vitamin E and selenium deficiency are direct risk factors. In fact, in certain high-risk areas in China, aggressively replacing vitamin E and selenium in the population literally caused the incidence of this cancer to noticeably drop. It's wild how impactful a simple nutritional intervention can be.
Moving right along to Section 2, presentation and diagnosis. Irrespective of the underlying histology, the absolute earliest and most common presenting symptom is progressive dysphagia, and it's highly specific. It starts with difficulty swallowing solids, and then, as the tumor grows, it progresses to liquids. Because the patient literally cannot eat, they experience severe, rapid weight loss. But we have to be hypervigilant for signs of advanced disease. If a patient presents with a chronic cough, that is a massive red flag. It usually signifies a malignant tracheoesophageal fistula, meaning the cancer has actually eroded right into the airway. If they present with hoarseness, well, the tumor has likely invaded the recurrent laryngeal nerve. And if you do a barium swallow at this stage, you're going to see classic strictured imaging signs, the rat tail appearance, the apple core deformity, or what's called a shouldering effect, where the broad normal esophagus abruptly narrows right at the tumor site.
You know, whenever a patient with these symptoms sits across from you in the clinic, they are really only asking two fundamental questions. Is it actually cancer? And where has it spread? Our entire diagnostic pathway is built from the ground up to answer exactly those two questions.
And that brings us to a very strict three-step diagnostic flow. Step 1, endoscopic biopsy. This is your investigation of choice to definitively confirm the diagnosis. We look directly at the tumor and we grab a tissue sample. Step 2, PET-CT. We use this for overall staging to see if there is any distant spread anywhere in the body. Step 3, endoscopic ultrasound, or EUS. This is specifically used to determine the exact tumor depth and the local lymph node status. Keep this sequence locked in your memory because these exact 3 steps apply perfectly to gastric cancers too.
All right, Section 3, staging esophageal cancer.
Before we talk about local staging, let's chat about that overall staging PET scan for a second. The isotope used is 18-FDG, which stands for fluorodeoxyglucose. And here's a hyper-specific, high-yield fact you just gotta know. The half-life of 18-FDG is exactly 109 minutes. It sounds like a tiny detail, I know, but it is one of those classic facts that separates the experts from the novices. So back to local staging using endoscopic ultrasound. When we put that ultrasound probe down the esophagus, we see these alternating layers of black and white. The rule of thumb here is the mucosa and submucosa appear white, or hyperechoic. Wherever there's muscle, like the muscularis mucosa or the muscularis propria, it appears black or hypoechoic. But wait, here is the absolute most crucial anatomical fact you must remember. The esophagus completely lacks a serosa. Unlike the stomach, which has a distinct white serosal outer layer, the esophagus just stops at the muscle. This lack of a serosa is precisely why esophageal cancers can spread so rapidly and easily to adjacent structures. There's no outer barrier to hold it back. Now, the gastroesophageal junction, where the esophagus meets the stomach, is a notoriously tricky area for tumors. We use the Seward classification to make sense of it. Type 1 tumors are 1 to 5 centimeters proximal to the junction.
Type 2 are 1 centimeter proximal to 2 centimeters distal, and Type 3 are 2 to 5 centimeters distal. So why does this matter? Well, it dictates the entire game plan. Seward types 1 and 2 are managed surgically just like regular esophageal cancer, but Type 3? That epicenter is so far down that it's treated entirely like a stomach cancer, which means it requires a total gastrectomy.
When we're talking GI cancers, remember, the T in TNM staging stands for the depth of tumor invasion. It is completely independent of the size. And honestly, T-stage is your absolute most important prognostic factor. Let's look at early T1 tumors. If the tumor is T1A, meaning it only invades the lamina propria, it's actually amenable to a much less invasive endoscopic mucosal resection, or EMR. But the second that tumor hits T1B, meaning it invades the submucosa, everything changes. You absolutely must do a full surgical esophagectomy. Why? Because the lymphatic vessels run directly in the submucosa. Once the tumor hits that layer, it has a VIP access to the lymphatics and carries a super high risk of metastasizing. And where does it typically go? Usually straight to the liver, traveling right along the left gastric vein into the portal circulation.
Let's dive into Section 4, Surgical and Multimodality Treatment. Modern cancer care is almost never just about surgery alone anymore. A crucial point we have to cover is neoadjuvant therapy. This means giving chemotherapy, like 5-fluorouracil, cisplatin, and taxanes, often combined synergistically with radiotherapy before we ever even touch a scalpel. The famous MAGIC trial really highlighted the massive role of this approach. For locally advanced tumors, meaning T2 with positive nodes, or T3 and T4 tumors, we use these heavy-hitting drugs to shrink and downstage the tumor beforehand. The ultimate goal here? To ensure that when we finally do go in for surgery, we achieve an R0 resection, meaning the margins are entirely microscopically clear of disease, leaving absolutely no cancer behind.
When we do go in for that esophagectomy, the rules are incredibly strict. Because esophageal lymphatics run longitudinally, there can be what we call skip metastases far away from the main tumor. To counter this, we require a massive 10 centimeter proximal margin and a 5 centimeter distal margin. Once we remove that section of the esophagus, we obviously have to replace it. The best replacement conduit is actually the patient's own stomach pulled up as a gastric tube. And you must know its blood supply. It is perfectly reliant on the right gastroepiploic and right gastric vessels. And as a quick aside, the source material shared this hilarious analogy. They compared pulling the stomach all the way up through a tiny hole in the diaphragm into the neck to an oriental white-eye bird twisting its neck upside down to do yoga. It's a wildly impressive anatomical manipulation.
So how do we actually perform the esophagectomy? There are 3 main approaches. First up, the transhiatal or Oranger procedure, which is mostly used for lower 1/3 tumors. It works right through the tight space of the diaphragm's hiatus using exactly 2 incisions, abdomen and left neck. Second, we have the Ivor-Lewis procedure for mid-third tumors just below the aortic arch. This one also uses 2 incisions, the abdomen and a right thoracotomy, with a connection or anastomosa made right in the chest. Third is the McCune or 3-field esophagectomy. This is for mid to upper third tumors and requires 3 separate incisions, abdomen, right thorax, and left neck. The McCune is universally considered the best for comprehensive lymph node clearance. However, because the connection is made way up in the neck, it does tend to leak a bit more frequently, though luckily those leaks are usually managed conservatively.
Opening up the chest and abdomen carries immense physiological stress, and the surgical complications here are highly tested. The single most common complication is atelectasis, or lung collapse. Why? Simply because the chest incisions are so incredibly painful that the patient refuses to take a deep breath. The most deadly complication, however, is an anastomotic leak in the chest. That dumps bacteria directly into the cavity, causing a rapid, often fatal mediastinitis. Another totally unique complication is a chyle leak. If the thoracic duct is injured during the dissection, you'll start seeing a turbid, milky fluid filling up the surgical drain. And there's a really clever clinical trick to confirm it. Just feed the patient a fat-rich diet. Literally give them butter. If it's a true chyle leak, the output in the drain will immediately spike.
And finally, Section 5, Palliative Care and Benign Tumors.
Remember that malignant tracheoesophageal fistula we talked about earlier? When the cancer is literally eaten whole directly into the airway, secretions and food spill straight into the lungs, causing chronic cough and severe pneumonia. This is advanced, incurable disease. At this point, our entire goal shifts to palliation, improving the patient's day-to-day quality of life. The absolute best management here is endoscopically placing a SEMS, a self-expanding metallic stent. It covers the fistula perfectly, allowing the patient to finally swallow their food safely again. But hey, I really want to flag this for you. The most frequently tested complication of a SEMS, it's migration.
The stent can literally just slip right out of place over time.
To wrap up the clinical picture today, let's briefly contrast these deadly cancers with the most common benign tumor of the esophagus, the esophageal leiomyoma. This smooth muscle tumor is mostly found in the distal esophagus and is actually twice as common in men. Here's the good news. They are usually completely asymptomatic unless they grow extremely large. If you do a barium swallow, you won't see that nasty, irregular apple core we talked about earlier. Instead, you're going to see a very smooth, very distinct, punched-out appearance. Because it's benign, the management is incredibly straightforward. We do a simple surgical enucleation, basically just popping the tumor right out of the muscle layer while leaving everything else intact.
Wow. Okay, we have covered a tremendous amount of ground today, from the cellular risk factors of squamous versus adenocarcinoma, all the way to those intense multi-stage esophectomies and palliative stents. But I want to leave you with this final provocative thought. Right now, early detection relies almost entirely on the patient noticing progressive dysphagia, and by then, the tumor is already big enough to cause a physical blockage. Looking at those massive surgeries and complex multimodality treatments we just went through, how can we develop better, proactive screening protocols for high-risk patients before the disease dictates such a radical, life-altering path? It is the absolute frontier of gastrointestinal oncology and definitely something to keep at the forefront of your mind. Thank you so much for joining me on this explainer, and keep learning.